Welcome back to the Infection Control Exchange. I'm Wayne Tucker, your host for this podcast, and I'm located in Halifax. And in this episode, we're going to take a candid look at infection control in terms of what we're doing well and areas that require improvement. So, my infection control thoughts are based on many years working in public health, acute care, long-term care, and primary care. And the goal isn't to criticize, but to reflect and to learn from our experiences uh, of infection control. So we've made important progress, but there are still gaps that where we need to make improvements, and we want to ensure that areas that we're doing well that we continue to do so going forward. So let's start with some good news. What's working well across infection control programs right now? Starting with the anti-hygiene program, I think most facilities do a pretty good job with their anti-hygiene compliance. It tends to be very high, but there is a reason why compliance is very high is that it's usually most places observe it via like direct observation, where staff auditors are right on the floor and people are being audited, know they're being audited for the most part, and that increases the chance that they're not going to change their behavior and do hand hygiene more often than they would be if you weren't on the floor doing the audit. So it's important to take that into consideration in terms of the compliance rate. So it may usually will be lower than that if there was no auditors on the floor. But for the most part, I think people try to do the right thing and are doing hand hygiene throughout their shift. We'll get in some of the areas that are missed in the next segment, but most people are trying to do a good job when it comes to hand hygiene compliance. And I think a lot of the facilities really do put some thought into where to put the hand hygiene dispensers and make it really easy for people to access the hand sanitizer. So, hand hygiene compliance, the programs, I think most facilities have got a pretty good program set up with the policies, auditing that certain number of audits that you need to do and stuff like that. So, I think it's most places have got a pretty good hand hygiene compliance our program in place. When it comes to, like, donning and doffing, I think it's very similar to hand hygiene compliance. I think their compliance rates are gonna be impacted by direct observation, as I mentioned with hand hygiene, so it's gonna be higher than it would be if there was no auditors on the floor doing audits. But I do think that there's good access to PPE, so that's very important. You wanted to make it very convenient and easy for people to access the PPE. And I think most facilities do a good job of putting the PPE where it needs to be and keeping it stocked as well. So I think that's both the anti-hygiene program and donning and doffing compliance are, for the most part, done very well. And we'll get into some of the areas of improvement in a few minutes in the next segment. I did want to talk about precaution signage. So when someone goes on precautions, a sign's going to go up. A couple examples could be a contact precaution signage for example, for multi-drug resistant organism. So they are on precautions, contact precautions, but they're not on isolation. They can leave their room, or the patients can leave the room at the hospital. So I think uh, those signage goes up, are put up in a timely manner, and that's important because you want to get the staff putting on the PPE as soon as we know that someone has got a particular infectious disease, and put up the appropriate signage. I already mentioned that the PPE supplies are well stocked, and inventory is good. So you got to make sure that you got, that the PPE bins are being stocked, but that you've got a main supply area where you're putting all the PPE that you're ordering, so you're bulk stock, and you make sure that keeping that up to date with at least a couple weeks supply. But that kind of varies depending on the space available that you have at your facility. Sometimes you might have to do orders every week, but hopefully you can do orders every 2 to 3 weeks. I do think surveillance, for the most part, in facilities is pretty good. I think most places, whatever their system is, are tracking new symptomatic residents and patients, and adding them to the EMR or any paper-based systems they have for surveillance. So, and that's really important for outbreak management. That you're looking at that on a daily basis, and seeing, for example, the IPAC manager or IPAC lead is looking to see, potentially if they're seeing an increase in the number of cases on that particular unit or a floor of the, for example, hospital or long-term care home. So, when you start to see a increase, something a little bit more than you normally would see in that area, then, it's a time to make a call to public health and just review everything with them and see, if it's meeting the case definition for a possible outbreak. So that's a chance for you to just be, I tend to be one doing it, be very proactive. And if I notice things are occurring on the floor, do make that call and review everything with public health. I think they appreciate homes and hospitals that make that call before things spread too quickly. So, in my experience working in public health, some places would call on a Friday afternoon and say that they have 12 symptomatic residents. And then you ask them, when did this all start? And they said, it started on Tuesday. Well, the first question is, why didn't you call public health much sooner when you noticed that you had an increased illness in your residents or patients? So you go through that process, but you got to deal with the outbreak. So you give them help them manage the outbreak. But there's a learning component to that, and you want to be checking with public health and getting in contact with public health as soon as you can. Um, Typically, one of the things I wanted to get into was staff at your home when they're sick. Most people stay at home when they're sick, and that is great. Um, we don't want people coming into the home if they're symptomatic. I think in terms of outbreak management, I think for the most part it's good in facilities, and I think that comes with a fair bit of support to help with manage the outbreak. So, which is which is needed. You're gonna need that support because it can get quite busy during an outbreak to manage everything. And if staff stay at home when they're sick, then you're less likely you're gonna see yourself in an outbreak. In terms of immunizations, I think most places do a very good job offering vaccines like influenza and COVID-19, as well as like RSV, offering other vaccines, routine vaccines as well. So I think most facilities got a well-developed immunization program that they follow every year. I do think, we're seeing stronger communications between the various departments like nursing, environmental services, dietary, infection control leads, etc. And I think that collaboration does a lot to prevent the spread of infectious diseases and prevent outbreaks from occurring. So I think um, when staff feel comfortable bringing up their concerns, and we're not operating in these facilities in silos, then I think you get to learn about or hear about symptomatic patients or residents a lot sooner when there's clear communications across the various departments. One of the areas that I want to move on to is eye touch. So I think I mentioned in probably one of my previous episodes of the podcast that I do think the environmental health side of things doesn't get enough credit for the work it does and how it impacts outbreak management and the spread and transmission of infectious diseases. So there's a lot that the housekeeping staff do in terms of disinfecting the eye touch areas outside of the patients or residents' rooms, as well as doing those eye touch areas in those rooms. So there's a number of things that you can technology there to use. You can use fluorescent sprays, which I've used, and you go around randomly picking areas in rooms and spray in eye touch areas, say 3 or 4 in a room, and then you spray areas outside the resident or patient rooms, and you record those spaces and what areas you spray with this fluorescent spray, and then you come back with a UV or a black light that you shine and just determine whether it's been disinfected or not by the housekeeping staff. And then you can bring that feedback back to the environmental service manager, and he can then look into who was working that shift or on that floor, and then provide them with feedback about how they're doing their eye touch disinfecting. And it's extremely important because during an outbreak, you're going to need to increase the eye touch disinfecting to help prevent any further spread of any pathogens like influenza or COVID-19. So the more that you do in terms of your eye touch and increasing it during an outbreak, the more likely you're going to get out of that outbreak sooner. Another thing, some equipment that I've seen and had a chance have it demonstrated is the use of equipment that tests for on the spot for organic matter. So you can kind of use that to provide your housekeeping staff with some feedback about how they disinfected a room. So you just kind of work with housekeeping staff one-on-one. You're using this equipment. You do a test before they disinfect a room, for example, and then you have them go in, disinfect the room, and then you do testing afterwards again and see, obviously you want to see a drop in the score after they've disinfected the room. So there's technology there that you can use to kind of help monitor and audit how well your eye touches areas are being disinfected within your facility. Just want to talk about the immunizations a little bit more in terms of the cold chain. So when you're running these various programs and stuff, DIPAC managers or someone else are picking up the vaccine from public health. You got to make sure that you're taking your cooler with ice packs in it and a towel so that the vaccine is not coming in contact directly with the ice packs. And then you're transporting that back to your facilities and then putting that in your dedicated fridge. I've worked for public health, so I have always recommended that facilities invest in actually buying a dedicated vaccine fridge or lab fridge and not a bar fridge, which is typically what you see. The bar fridges can be unstable with the temperature, and they were never really meant to store vaccines. So it's not the best fridge to be using for your immunization programs. So in terms of the cold chain, you're responsible for maintaining that cold chain right from the start. So right from when you pick it up, you got to have that, like I mentioned, like that cooler with the ice packs. And you're responsible for it, not for just when it gets back to the fridge and you put it in the fridge, what you need to do right away. But it's right from that point until you actually give the vaccine to, the residents or patients, you're responsible for that vaccine. So when you take it out to go do your immunizations, you need to have the cooler ice packs in the coolers and take that up to the floors to give the vaccine. And so you're responsible for maintaining that cold chain right from the start, right up until you actually administer that vaccine. In terms of lab testing, I think most places I've got a pretty good system. From my experience, and I do a very good job with their lab testing and getting it done as quick as possible, so that they know where they are. For example, if you're seeing an increase in symptomatic residents, you can administer uh, the appropriate PCR test and hopefully get the results back in a couple of days. That tends to sometimes fluctuate, but you want to get those results back as soon as possible. Um, in in terms of the next area I want to cover was, I think COVID-19 and the pandemic created some high standards to meet. And I think most places are working quick to make the adjustments that they need to make for those higher standards, regulations, guidelines. So I think infection control is much more on the radar for a lot of people since the pandemic. And I do think that's a very good thing. Um, some people may not agree, but I think it, especially for long-term care, I think it's changed a lot of the standards or the quality, the high standards that you need to meet. And I think it's taken it to a better area, a better place where you can improve, where we're improving the infection control programs within long-term care, for example. So, so there's many things I think that to celebrate, I guess, that we're doing a great job uh, in these facilities, and I think staff are working very hard to implement a very good infection control program and protect the vulnerable residents and patients. Um, but while we've come a long way over the last few years, like as I mentioned, since COVID-19, there's still areas where infection control isn't meeting its full potential, and these are the things I want to get into in the next segment. That we'll talk about what isn't working. So to start off, areas that are not working as well. Okay, I'm going to start again with anti-hygiene compliance. We've already talked about direct observation. So, you know, there's still areas within anti-hygiene that staff need to make improvements upon. So one of the things that I've done when doing orientations and stuff is to review with staff, for the anti-hygiene uh, areas that, you know, they're missing, for example. So it's important to provide feedback. Are they doing their wrists? Are they doing the thumbs? Are they doing their fingertips? Reminders about anything that's interfering with doing their eye and hygiene, so any jewelry, for example. So these are all things, feedback that you want to be given to staff, so they learn and they understand why these policies are put in place. So that feedback needs to be provided, on the spot, and show them and to explain to them what areas that they're missing, because it's going to be different for different people. Some staff might get close to covering all the areas, but they might be going too fast. And, you should be in that range of about 15 seconds to adequately cover all the areas of your hand. The PPE donning and doffing compliance, like I said, that should be I, and I think most places it is. But you learn some of the things, and like, I also do that in orientations as well, and education sessions that you got to get into the very specifics of donning and doffing, and look for areas where what are being missed. So, are they covering all their areas, you know, for example, are they wearing their mask appropriately? Is their nose covered, for example? Are they putting on their gowns properly? Is it tied? Is there any gaps in the back? Uh, Things of that nature. So, are they putting their gloves on appropriately? Are they putting on their face shields appropriately? So you want to provide that feedback. One of the things that I've in the past provide education to staff is and when doing orientations or on the floor education is that we have to help one another. So as I mentioned in the previous post, it's kind of like health and safety. You got to be willing to help one another and help build that culture. So if you see a colleague with the back of their gown exposed and they're about to go into a resident or patient room, then just stop them and say, you just need to fix your gown in the back there and assist them if they need some help. So it really is a team effort to protect everyone. And donning and doffing is no different than like hand hygiene. So if someone missed doing their hand hygiene, just explain to them that you didn't do your hand hygiene going into that rooms. And I also think we need to empower the patients and the residents as well. And for them, if they notice that someone's coming in the room to provide care and they're not wearing the appropriate PPE or they haven't done their hand hygiene, for example, to remind them to do the hand hygiene. So I'm certainly a strong advocate for putting signage up to remind healthcare providers to do the hand hygiene and to wear their PPE. I did mention earlier that for the most part, precaution signage is put up pretty in an appropriate time, but we do have to be careful that you know we get the signage up when it needs to go up, so the precautions can be put in place as soon as possible. But also, we got to make sure and be careful that we take someone off precautions as soon as possible. So we don't want to have them up on precautions any longer than they need to. So, you're reviewing your guidelines and you're in contact with public health, and you take people off precautions as soon as possible so that they can get back to seeing their friends at the dining table during their meals and everything. Saying we don't want people on the precautions any longer than they need to. And I know sometimes there's gaps in that area, so we always want to be working towards closing those gaps so we get residents off of precautions as soon as possible. In terms of eye touch disinfecting and the audits, I mentioned that. So, and I mentioned some of the tools that are in place to help with the eye touch disinfecting. One thing with that is you got to make sure that you increase your eye touch in a timely manner when you go in outbreaks. So as soon as you go in an outbreak, those designated areas that are an outbreak or public health may want the entire facility to increase their eye touch. That you're doing so, and that you're providing feedback to the staff. That's very important that you track all those areas that you're doing the audits for, and then giving, as I mentioned, the environmental services manager feedback on areas that are being missed on, in resident rooms or the railings, for example, and so that improvements can be made, because those gaps impact the transmission of infectious diseases during, on a daily basis, as well as during outbreaks. Daily staff idles, is one of those areas where you can just kind of quickly review things, IPAC with staff and anything areas where improvement is needed. Not staff are not always, looking through their email or reading their email as often as they may should. But you need to be kind of, doing those quick huddles with the staff and providing some feedback about where the improvements need to be made. On surveillance, I think, for the most part, as I mentioned, it's good, but some of the areas that where improvements are needed is ensuring that whatever way you do it in your facility, that there's no gap. So those gaps can impact an outbreak, whether one is declared or whether it's declared over by public health. So you need to be tracking all your infections within for residents and for patients, and make sure that's matching the EMR. So whatever way you do your surveillance, you got to make sure that all your documentation across the different pieces, whether some of it's paper, some of it's in a electronic medical record, that's all matching. You don't want to be a mismatch between that. So you got to watch out for your gaps with that, because that surveillance stuff, surveillance information is extremely important for seeing a potential outbreak happening in your facility. So in terms of residents on precautions, I've mentioned that, make sure it stays current. We don't want anybody to stay on any precautions any longer than need to. So I'm not going to go through that part of it again. I've already explained the reasons why. In terms of outbreak management, one of the things that I've noticed from working on many different sides of it is that, and I think COVID-19 has increased it. So line listing has always been a common practice, to put all your residents and as well as staff on the line listing. But things have changed over the years, I think, especially since the pandemic. So I think you got to keep that constant communication with the staff, providing updates through emails, through meetings, through the audits, and work on building that infection control culture, right? So it's very important for outbreak management and for IPAC or infection control in general, that you're working on building that culture, because you want to build a culture that staff really understand why these infection control measures are in place and why all these protocols need to be followed, right? So in the training that I do, I'll always explain that, you've chosen to work with a very vulnerable population, whether it's a patient or a resident of a long-term care home. So, you've made that choice of where you want to work. So now it's your obligation to do everything you can to protect those residents. That means staying home if you're symptomatic until until you're feeling better and no longer symptomatic. So we got to always think about where we decided to work, and make sure that we're doing everything we can to protect our vulnerable residents and patients. So in terms of another area I want to talk about is gaps in N95 fit testing. I think I should have mentioned earlier, I think for the most part we do a pretty good job of it, but it can sometimes get beyond, we can sometimes get behind in our fit testing, especially for new staff. We got to make sure that we have them getting fit tested in a timely manner. Ideally, they should be tested before they start their first shift, because you never know when an outbreak is going to be occurring. And you want to make sure that they have the appropriate mask fitting for them if it's needed. So we should continue to do the N95 fit testing. In terms of IPAC orientation, when new staff come on or staff returning, we should be doing the infection control training. So that's usually going to be completed by the infection control manager or the lead. So, but sometimes departments are in a hurry to get staff scheduled and on the floors, but those gaps shouldn't be occurring. You want to make sure that you get all the staff, get their training, get the fit testing done, really ideally before they start their shift. So I think, having good communication is important across all the departments. and make sure that, you make yourself available to do that training. I usually, unless I'm was in a meeting or something, did the training as quick as possible, same day. Uh, Usually it was, one-on-one or a couple new staff that's starting. But important to kind of get that done as, as soon as possible so you don't have any gaps. When it comes to immunizations, it varies probably quite a bit across facilities. I think sometimes immunizations for patients and for residents is usually much higher. That's certainly good to see. For the most part, the uptake for COVID-19 vaccines and influenza vaccines are high, and that the residents getting the necessary protection. Not everybody, all residents are going to be willing to get it. There's going to be some refusals, either by the residents themselves or by the POA. Um, but we want to make sure we work on our staff immunization rates, and offer incentives, prizes, contests, gift cards to get it up to the highest you can. I've worked in some places where it's been for staff, for influenza, it's been, uh, you know, close to 90% or over 90%. Getting those numbers from COVID-19 is harder, or I haven't quite seen them as high as like that. But I did mention that in the first episode for this podcast that it's been a more difficult sell for the COVID-19 vaccine, but they do need to think about it in the same way as influenza. If they don't get that most recent vaccine, then they're not going to be protected from that current strain. Um, some gaps in lab testing that I've seen that have had big implications, especially during an outbreak, because it can cause delays in getting results. Usually what's happening is that the lab requisition is not being filled out in an appropriate manner, and there's gaps. And what happens is that the public health labs refuse those samples. They don't test it, and that can really throw a wrench into things in terms of outbreak management, because you're going to have to retest, and sometimes it's too late to retest the resident or the patient. It can delay, cause an extension to an outbreak, which you don't want. You want to get out of an outbreak as soon as possible, for many reasons. So you really got to be careful with those gaps that might occur with the lab testing. So just watch for that. Um, I do think most of the infection control programs have got good leadership in place, but I think we do need to watch out for the workload for IPAC leads and managers, because I think what happens, um, and I probably wasn't as aware of this when I worked in public health, and maybe things have changed as well since COVID-19, is that there's a lot more meetings, there's a lot more paperwork, there's a lot more reports, uh, that need to be completed, that increases the workload for the IPAC managers quite significantly during an outbreak. Um, and then the downside of that is they're not on the floor as often as they should be. So it takes them away, and they're in the office more often, and spending less time on the floor, which is really not what you want to be seeing. You want to see those IPAC managers out on the floor, um, going around and checking to see how IPAC measures are being implemented. So that's just a downside that I've seen over the years, is that during outbreaks, you don't get on IPAC leads and managers and on the floors as much as that they should be, and would like to be, but they have to do all this paperwork and reports and websites they need to go to and everything for all the channels, for the communications for everyone. Um, I think the increase in the standards and guidelines, which I mentioned earlier, I do think it's a good thing that's come out of COVID-19, but it does make it a challenge to meet. So we do need to ensure that the IPAC managers and the leads have the staffing resources that they need to meet them. So all these standards, guidelines, regulations are great, and I certainly have welcomed them. But it's going to make it a challenge to achieve it for the IPAC lead or IPAC manager to meet everything that needs to be done with these new standards and guidelines and regulations. So you got to make sure that you're putting in the staffing resources to support them as well. Documentation, I think that's probably an area for anybody where they need to make sure they got the appropriate documentation from meetings, from their infection control committee meetings, from their outbreak meetings, from their health and safety meetings. So all that documentation is very important, as well as all the documentation for any outbreaks. So you got to make sure you got files created to paper or on your computer for all those outbreaks, and you get them organized, because you're going to be asked to show documentation when there's an audit from, for example, from a ministry for long-term care coming in, and they will ask for all that information, and you got to be able to provide that in a timely manner to them. So the more organized you are, and you can show them that information when you're being interviewed and answering questions, they just want to see it. So many times I would just be able to pull up that information on my computer, show them what they were asking for in terms of the documentation, and they take a quick look at it and see that you've got the documentation in place, and then they're quite happy. It is when, you got delays in providing the documentation, or the documentation is incomplete, that's the kind of situation that's going to get that facility into some trouble with the appropriate ministry. So, um, in terms of the maintaining, just quickly about the cold chain, I've already talked about that. You got to, your responsibility is when you're giving a biological, so like you're giving a vaccine, is that you're maintaining that cold chain at all times. So I'm just putting that in there, making sure that that cooler is being taken with ice packs all the way until it's being administered to the resident or the patient. So it's always important. We don't want any vaccines to be out of cold chain for any amount of time like that, and that you give it in an appropriate way while maintaining the cold chain. The final thing that for this segment that I want to get into is the infection control culture. I do believe that needs work in many facilities. So, and by that I mean it comes back to understanding where you're working. So you're working with the most vulnerable people, patients, and residents. Uh, so you've made that decision to work in healthcare. So you need to do everything you can to protect those vulnerable residents and patients. So we need to work on building that culture where we're willing to help one another. So if you see someone with, they're not wearing their mask appropriately, it's got their mask under their nose, or on their chin, or the mask is hanging from one ear, that you inform them that they're not wearing their mask correctly, and have them, make the adjustment and fix how they're wearing their mask. So you got to, and it's the same thing for donning and doffing and hygiene, that we're helping one another out and building that culture, because that goes a long way. And IPAC managers and IPAC, leads and champions are not going to be everywhere. They're not working every shift. You need to work on building that culture from the ground up, from the frontline staff. It will never work if you're building it strictly from a top-down kind of management style approach. You've got to empower the frontline staff to help one another and build that culture to control the spread of infectious diseases, to improve upon the infection control program, And then you'll have something that will last a very long time. Always need to work on it, but when you get that culture built, um, you come a long ways in terms of improving infection control. In the next segment here, the theme of this year for the National Infection Control Week, bridging gaps and building bridges. I think it fits perfectly. You know, every audit, every outbreak response, every lesson learned is a chance to connect better across our teams, right? So that collaboration is so important. Like I mentioned, so important building that culture. So whether you're in long-term care, acute care, public health, infection control leadership means showing up, listening, and keeping prevention visible. So the role of leadership is being out there on the floors as well, showing people that you're got a presence there and you're available to answer any questions that may come up. So as we wrap up this episode of the podcast, I want to thank you for tuning in to the Infection Control Exchange. If this episode makes you reflect on what's working and what still needs work, I'd love to hear your thoughts. Please like the posts for these episodes and drop a comment, and be sure to share the Infection Control Exchange within your social network. Um, there are just so many areas that impact infection control, and I tried to touch on many of them today, but I know I didn't get to cover them all, and I might dedicate another episode in the future on talking about what is working in infection control and what is not, and where improvements are needed. So you can listen to all episodes on Spotify, Apple Podcasts, YouTube, and soon Amazon Music. And of course, follow along on LinkedIn for upcoming discussions. So until next time, keep leading, keep doing well with your infection control programs. I know everybody's working very hard, and keep building those bridges to improve infection control. Thank you very much.